At the proximal convoluted tubule, the most metabolically active segment of the early nephron, carbonic anhydrase inhibitors such as acetazolamide exert their effect. By inhibiting both the luminal and cytoplasmic isoforms of carbonic anhydrase, these agents prevent the dehydration of carbonic acid into water and carbon dioxide within the lumen, as well as the subsequent rehydration within the cell. This disruption halts the production of hydrogen ions necessary for the sodium-hydrogen exchanger, thereby blocking the reabsorption of sodium bicarbonate. The clinical consequence is a mild diuresis accompanied by significant urinary alkalinization and the development of hyperchloremic metabolic acidosis. This mechanism is particularly high yield for its application in treating open-angle glaucoma by decreasing aqueous humor production, and in managing acute mountain sickness by inducing a compensatory metabolic acidosis that stimulates ventilation. Within the same proximal segment and extending into the descending limb of the loop of Henle, osmotic diuretics like mannitol operate through physical chemistry rather than protein binding. As a pharmacologically inert substance that is freely filtered but not reabsorbed, mannitol increases the osmolarity of the tubular fluid. This high osmotic pressure opposes the action of ADH and directly extracts water from the intracellular compartment and the medullary interstitium into the lumen. Beyond the kidney, this osmotic shift is utilized to reduce intracranial pressure in cerebral edema and intraocular pressure in acute glaucoma. However, clinicians must remain vigilant for the initial rapid expansion of extracellular fluid volume, which can precipitate pulmonary edema in patients with pre-existing heart failure. Transitioning to the thick ascending limb, we encounter the most potent class, loop diuretics, including furosemide, bumetanide, and ethacrenic acid. These agents achieve their effect by reversibly binding to the chloride binding site of the sodium-potassium 2-chloride cotransporter on the apical membrane. This inhibition not only results in a massive delivery of sodium to the distal segments, but also dissipates the corticomedullary osmotic gradient. Because this gradient is the engine for water reabsorption in the collecting duct, its loss results in the production of large volumes of dilute urine. A critical correlation is the effect on the transepithelial potential difference. By blocking the back leak of potassium, loop diuretics decrease the positive luminal charge that normally drives the paracellular reabsorption of divalent cations. This leads to the characteristic increase in the excretion of both calcium and magnesium, making loop diuretics a primary treatment for symptomatic hypercalcemia. Despite their potency, they are associated with significant adverse effects, including ototoxicity, especially when administered at high doses or in combination with aminoglycosides, and the development of hypokalemic metabolic alkalosis due to increased distal delivery of sodium coupled with volume contraction.